Okay. Would you like to start off with a quick introduction to who you are and what you do?
Yeah, sure. So my name is Chineze Ebo. People just usually call me Chi. I am a second district resident at Cincinnati Children's Medical Center. I am originally from the suburbs of Philadelphia. I went to undergraduate at Cornell University in upstate New York, and then I did a post-bac program at Dominican University, which is in kind of like about 40-ish minutes outside of Chicago. And I was in that program for about 2 years. I was a psych major at Cornell. I did some pre-med classes, but I didn't do the full pre-med classes, and I also wanted to enhance my GPA. And so that's why I ended up doing a post-bac program for 2 years and ended up getting a degree in medical science from that post-bac program. And then I went on to go to medical school at Chicago Medical School at Rosalind Franklin University, and graduated in 2019, and then started my pediatric residency at Cincinnati Children's. And so here I am.
Could you talk a little bit about the match process and what goes into that?
Yeah, so the match process is extremely terrifying. And I feel like I don't have that, good of a grasp on exactly the intricacies of like how the actual match itself works logistically. But with matching, essentially, so you go through your 4 years of medical school, and at the fourth year is the year that you plan to apply to residency. When you're applying to residency, you choose a specialty of your choice. There are some people who might end up applying to two different specialties, but for the most part, you do apply to one specialty. And so you will send an application that's very similar to a medical school application, only it's similar to a application you would send to get into medical school. But it's a residency application. It consists of a personal statement, letters of recommendations, basically your grades from, all throughout medical school, how you did on your clerkships, all of that information, and you send that to several different residency programs of your choosing. There is no limit to how many residencies you can apply to, but there are guidelines out there for, based off of some of your statistics, how many residencies you should apply to. And so once you select the amount of residency you want to apply to, and also kind of select maybe specific geography locations that you want to be in, whether you want to stay East Coast, West Coast, Midwest, you will submit your application to those programs via their electronic application service. You'll get interviews, and you interview essentially basically October through January, February. Right now, and with this COVID season, it's a bit different. But you interview, and then you make what's called a rank list, which basically allows you to rank the programs that you would most like to go to in order of preference. So your number one program would be the program that you want to be at, and you rank all the places that you interviewed at along that rank list. You submit your rank list, and then the residency programs also submit their own rank list of the students that they would like to come to their programs. And so they call it a match because basically your rank list coincides with the program's rank list, and they'll match you to a program that you want to go to that also wants you. So it's kind of like dating match kind of picture. And so then you have what's called match day that happens usually mid-March, where you find out where exactly you've matched. And it's not like, the medical school application where you can pick and choose where you decide to do residency. Typically you match to one program. And when you match that program, that is the program that you will go to. It's not like you match at different programs and you can decide. You find out, the one program that you're going to, and that is an actual binding contract, so you're not able to get out of that. So I say that because it's important for you to make sure that when you're making your rank list, you rank programs that you truly would want to be at, because if you end up matching there, you have to go there.
And now that you've been in residency for a little bit, can you talk about what a typical day would be like?
Yeah, so residency has long hours, and it kind of depends on what rotation you're on. So let's say that I'm on a normal hospital medicine or inpatient rotation. Typically, I would get to the hospital anywhere between 5:50 and 6 a.m., and I would receive sign out from the team that's been there overnight. Sign out is basically them telling me about any new patients that they admitted overnight, and also giving me any updates about the current patients that we have on the floor. Once I get sign out, I do something called pre-rounding, which is basically looking up all the information about the patients that are on the floor, checking their vitals, seeing, if anything happened overnight, basically looking into anything that the night team might have told me about what happened with the patient, and coming up with an assessment and plan for the day. So, okay, what's going on with this patient? Are they getting better? Are they getting worse? What are the interventions that we want to do for them today? Do we want to consult any other teams to help us with the management of this patient? And coming up with that plan so that when we do talk about the patients during rounds, I'll have a kind of baseline plan that I want to do. After I pre-round, I typically will check on my patients and make sure that they're all stable before we actually start our formal rounds. And then we have something called morning report, which happens around 7:30. And at that time, that's just morning lecture. Either we talk about an interesting case that happened, or get lectures about any sort of pediatric pathology or diseases. After morning report, then we do formal rounds, and rounds basically consist of the entire medical team. So that could be an attending, residents, nurses, and then any allied health professionals like respiratory therapists, nutritionists, social work. We'll gather and we will meet actually at the bedside. Pediatrics loves to do family-centered rounds, meaning that we want the families to be part of our rounds. We don't just want it to be a medical team talking. We want the families to be able to ask questions and be involved in their child's care. It's important. So we gather at the bedside of the team, have formal rounds, talk about the plan, answer any questions the families have, make sure everyone's on the same page. And we do that with all of our patients. So as you can imagine, rounds can take a long time if we have a lot of patients on the floor. But for the most part, we tend to try and be done with rounds by around 11:30 a.m. And that's because we want to make time to make any calls we need to make, do any discharges, just essentially make sure our patients are stable before we go to noon conference, which is, again, it's lunchtime. Cincinnati Children's is great, and they provide us both breakfast and lunch. So it's a great way. It's time for us to go and get our free food and also do some learning, some interactive cases, any didactics at that time. Afternoon conference, it's typically time for any teaching that we want to do with our medical students or interns or anyone on the team, to talk about any interesting patient cases or any information. We also admit children at that time if they come from the ED or if they're directly admitted from some other hospital. We do discharges and basically just kind of tie loose ends in the afternoon before the night team comes in. They usually come in around 5:30 p.m. and then we'll do another formal sign out where we tell them about all the things that happen with the patients during the day and things that they need to pay attention to overnight. And so typically a day can be anywhere from 5:30 sign out takes 30 minutes. You're there basically from 6 to 6. I've had days where it's been longer because we've had complicated patients, things happening, but it is a pretty full day.
And with all that working and all that time you use, you're obviously, working very hard. How do you keep your mental health in check and things like that?
Yeah, I think the program does a really fantastic job of trying to promote resident wellness. And resident wellness is a lot more than just like, oh, we're gonna have a pizza party every month. Like that's not how we do that. Resident wellness is a lot about making sure that we have good work-life balance, making sure that there's flexibility in our schedule. So when life happens, when emergencies happen, when COVID happens, you're able to have that luxury of having time off if you need it, if you need days off, being able to accommodate that. So, I think a big thing is being part of a program, obviously, that helps to facilitate that. Making sure that you have a good support system within your residency. So making sure that you have, good friends who you can spend time outside of the hospital with. I have a lot of movie nights, wine nights, little activities. We have picnics. I have a pool at my apartment. I'll have people over to the pool. So just like doing a lot of things to just ensure that I'm spending time with people that I, want to have fun with. Making time to talk to my family is important. seeing, time to travel, although it's not really happening right now, but just in general, just trying to make sure that the things that I like to enjoy are still happening. And it's harder some months than others, especially when you're getting into those difficult months when you're doing ICU or call months where you're working 28-hour, 30-hour shifts. But I think that a lot of it is just trying to make sure that the things that you love to do aren't getting lost. And so that's what I've tried to do. I love listening to podcasts, and I've been doing that when I drive to work. I like writing, I like going to museums, and before COVID hit, I was doing a lot of that. So I think it's really just about making sure that you have a good work-life balance.
You briefly touched on when you're in the hospital, you work different rotations. So I was wondering if you could talk a little bit about rotations and subspecialties.
Yeah. So like I mentioned, your main one that you'll have is a general inpatient hospital medicine rotation, where it kind of admits all your general pediatrics issues. So children coming in with asthma, bronchiolitis, if they have constipation and they need outs. Some of our teams kind of have more specialized things. So they're hospital medicine inpatient, but they have some specialized things that they'll see. One of our teams typically sees like the genetics kids, or the kids who have any sort of eye issues. If they have like orbital cellulitis, preorbital cellulitis, conjunctivitis, that's not, you can't treat outpatient. They'll see that. Other teams will see like our rheumatology patients, so our patients who might have some joint issues and might need to come in to be admitted for that. So we have that team. And then in terms of subspecialties, last year when I was an intern, a subspecialty that I was on was nephrology, which is kidneys. I was on pulmonology, which deals with the lungs. I was on endocrinology, which is endo, deals with the hormones. I'm actually currently on an endocrine elective right now because I think that that's what I want to do with my life. So that's been really interesting. We did cardiology elective, which deals with the pediatric heart, and saw a lot of heart transplants and management of congenital heart diseases. So that's really, really interesting. So there's quite a bit of specialties that you'll see when you're a resident, and the exposure that you get, and you can choose to get more exposure in one particular field. I have friends who are doing a cardiology elective right now because they are interested in doing cardiology, pediatric cardiology in the future, and I'm on an endocrine elective because I want to do pediatric endocrinology. So there's so many specialties in peds, and I think that's one thing that I really love about the specialty, that there's so many different paths and avenues that you can go down depending on your interest.
Could you talk a little bit about why you think it's important to diversify the healthcare field?
Absolutely. So I can speak even from examples that I've had here. It is not uncommon for me to, during my clinics when I'm seeing patients, walk into a room of a Black family and have them kind of stare at me with wide eyes because I'm the first Black provider that they've ever had. It's very humbling, but it's also kind of a wake-up call. Like, this is exactly why representation matters. We need minorities in medicine. We need physicians that properly reflect the patient populations that we're treating. There's data out there that shows that patients feel somewhat more comfortable having a provider who looks like them and can relate to them on a level outside of just, of medicine, that they can relate to a cultural background or even, ethnicity. And so it's important that we are creating a medical staff that can relate to patients and can just reflect what our patient populations are. I think that minorities, it's not just necessarily knowledge, but there's, again, like we're talking about social determinants of health and being able to relate to those backgrounds, because I think that there are, especially like some of my own classmates who have personal experience dealing with these things and being able to relate to patients on another level. That's just super important. I'm a big, advocate of making sure that you're creating an environment for your patients that promotes trust, that promotes, them feeling comfortable enough to come to you and open up to you, because a lot of health decisions, especially in pediatrics, will come with trust. When I'm talking to a family about vaccines, they're not going to trust me unless I create that environment. And I think a lot of that comes when they can relate to you. I've had parents tell me, like, as a Black woman, what would you do? Or as, you, from your experience as a Black female, not even a physician, as a Black female, how do I navigate the process? And so I think that there's a lot to be said about what experiences, URMs, underrepresented minorities, can bring to the field, and how important that is to the patients that we're going to be taking care of. So I think it's extremely important to diversify, not only as to, create comfort, but also to just create culturally competent physicians who are able to kind of adapt and relate to different cultures. I think that there's so much meaning behind that, and it's extremely important.
How is being a Black woman going through medical school, undergrad, residency, etc.? How has that affected your experience? Have you faced any racism, etc.?
I think that a lot of it has been people doubting my ability. Even when I was in high school and I got into Cornell, I had kids, my classmates being like, "Oh, how did you do that? Affirmative action is real." A lot of that, people doubting my abilities, and not necessarily based on anything but my race, because, not to toot my own horn, but my grades in high school were great. But I also was like, class clown. I like to make people laugh. And so I think people couldn't fathom, like, oh, this Black girl who makes a lot of jokes is smart. And I feel like that was kind of the theme. And I think it's a theme for a lot of, minorities in general going through medicine. There's a lot of doubt and people thinking that they just got to where they are because of things like affirmative action, and not by their own merit and skill and intelligence, which is something that we definitely need to change, because that's not the case at all. In terms of like overt racism, I don't know that it's been, that extreme versus just microaggressions. A lot of people assuming that, I'm the nurse, or, the custodian, I'm here to take their tray, versus the fact that I'm not the attending, the resident. Like I'm the doctor coming in to actually talk to you about your plan for your child. I have my badge, I have my stethoscope, and, it's kind of, it can be upsetting at times, because it's like, no, there's not really a way that you could have, thought that I was something other than one of the physicians, because I'm coming in with all this gear, So I feel like there's a lot of microaggressions that happen, a lot of assumptions that are made that I've had to deal with, not just only being because I'm Black, but also because I'm African. I'm 100% Nigerian, and so people will see my name and automatically make assumptions from that. And so it's just something that I've kind of learned how to navigate, unfortunately, throughout the whole process. I think that nowadays it feels like people are more willing to talk about it. I think a lot, before things were brushed under the rug and people were not really trying to be open to their own implicit biases and have a conversation about it. But nowadays, I think that people are a little bit more willing to have conversations about it and address, microaggressions and biases that kind of alter how they treat people in and out of medicine.
If you had one piece of advice you can give to pre-meds and aspiring doctors, what would it be?
It would be to, and I feel like I give this piece of advice all the time, but it's resonated with me. I think it would be to focus on your journey. Try not to compare yourself to other people. Comparison is truly the thief of joy, and it will do nothing for you except, push you back and serve to motivate you less. I think that in medicine, it's a very forward-thinking sort of profession where we're always looking for the next goal, right? So as a pre-medical student, you're looking to get into medical school. And once you get into medical school, then the next step is you want to take your boards. You want to take step 1, you want to take step 2, and then when you're done with that, you want to plan to match to residency. And then when you're in residency, you want to take step 3. And then once you're done step 3, it's just like a never-ending progression. And I think we have a habit of, we're great at being goal-oriented and trying to attain those goals, but we have a bad habit of not actually celebrating where we currently are, right? Like once you get into medical school, you're thinking about the next step, but you're not celebrating the fact that you got into medical school. This is what you prayed about, like how many months ago? And I think, we don't do a good job of like patting ourselves on the back and embracing where we currently are in our journeys, because that in itself should give you enough motivation to continue. If I embrace where I am and know that I was not here however many months ago, and I prayed to be in this current position, it gives you motivation to keep going because you know what you can attain, you've seen what you can do, and you can appreciate your accomplishments. And so my advice is always to remember that, like, even if you're not where you want to be exactly in your journey, remember that there was a point in time where you wanted to be exactly where you are, and embrace that and learn to use that to help you move forward. Congratulate yourself. Medicine is hard. Getting into medical school is hard. Getting through medical school is hard. Getting into residency is hard. Being in residency is hard. It's difficult. People are not doing this, although it seems like it, because I think we're all surrounded by like these medical people and it feels like this is what normal life is. It's not. It's very different from what people are doing. And I know that because I have friends who are not in medicine, and I suggest that too. Have friends who are not in medicine so you can keep your sanity. But I think that it's important to realize like this is difficult and not everybody can do this and not everybody is doing it. And embrace yourself. If you got a test and you got an A, own that. You did that. It's hard. And keep using that to propel yourself forward and you'll be fine.
Dr. Seltzer, do you have any questions?
No, I don't. Dr. Ebo, thank you. That was fantastic.
Thank you so much for having me. I appreciate it.
Yeah, I think we will end the call on that wonderful advice. So thank you so much for your time today.
No problem. Thank you.